Hello, everyone. I think it's 3 o'clock. Thank you so much for tuning into our live broadcast. This is our first one, so bear with us. You can tell we're going crazy sitting around at home. But we're in the office and we have a really special day today. And I would like to introduce Sue Goldstein, the person that just keeps us all together and going in the right direction, because basically a room full of spine surgeons is like basically a room full of cats. So I'd like to introduce Sue, who is a mover and shaker in this field, and I'd like her to make some introductions and explain kind of how the day is going to go. Sue.
Thank you, Dr. Kim. You'll note that we're having our 6-foot separation, social distancing, so you're not going to see us on the screen at the same time, except for at the end where we'll maintain the distance. So welcome to the Facebook Live first event by the Center of Excellence for Genitopelvic Dysesthesia. I know that sounds like a really strange word, dysesthesia, but what it means is that abnormal feeling. That could be pain, it could be unwanted arousal, it could be burning. The most common genitopelvic dysesthesia is persistent genital arousal disorder, and I know many people who are watching today have that problem. One member of our group is Dr. Barry Komisarek. He is a distinguished professor of psychology at Rutgers University in Newark. And unfortunately, his social distance is a little too far to join us today, but hopefully he'll be joining us in future events. Our other speakers are Dr. Irwin Goldstein, who is the director of sexual medicine at Alvarado Hospital, director of San Diego Sexual Medicine, a clinical professor of surgery at UCSD, and editor-in-chief of Sexual Medicine Reviews. And in case you notice the last name is similar to mine, he is my other half. Our other speaker today is Dr. Choll Kim. Many of you know who he is since you're already on his Facebook page. He is at Spine Institute of San Diego. He is I want to get it right. He is the director of the Minimally Invasive Spine Center of Excellence. And like Dr. Goldstein, who started the International Society for the Study of Women's Sexual Health, Dr. Kim helps found the Society for Minimally Invasive Spine Surgery. Now, after our speakers finish, we will open up to questions. So please write them in. We will interrupt if there's a pressing need for a response. Otherwise, we may wait until our speakers are finished. We're lucky enough that Dr. Komisarek will be joining us by phone to help with the questions. Please note there's a 15-second delay in this presentation in the video. So if you ask a question and it takes a little while for us to get to the answer, please be patient. Our speakers will do their best to answer as many questions as possible. Housekeeping notes. Don't forget to put your phones on vibrate. The restrooms are down the hall and to the left, or to the right, or upstairs, or wherever they are in your home where you were doing your distancing. We wish you all good health, safety from the coronavirus, and improvement in your sexual health. And at the end, we'll come back for questions. So at this point, I'd like to introduce Dr. Irwin Goldstein.
Sue, thank you very much. I just took off my mask, so I'm mask-free. I want to say hi to Linda. Hopefully you're out here, and Nick and Eveline. All of you are leaders in the Facebook support group, and thank you for being with us for this. I just spoke on the phone with Jennifer and Liesel, and I just want to shout out to you. We're here to help you guys. The title is Overview of Sexual Dysfunction, and I'm going to put my hand here to show that you probably can't see all these words, a little small, but we try and divide sexual issues into those which are biologic or organic, or the term here is physiologic. We add the pelvic floor family with musculoskeletal disorders, and then the psychosocial issues which relate to sex therapy, psychological, interpersonal, and socioculture. We have on our facility in San Diego Sexual Medicine all of these people in one roof, and this is our facility in days prior to COVID, when we can actually sort of sit near each other. At the heart of everything we do is the World Health Organization statement that gives everybody the right to all of health, but in particular, as we relate to the right to sexual health. So you have the right to enjoy and control your sexual and reproductive behavior in accordance with the social and personal ethic, freedom from fear, shame, guilt, false beliefs, and other factors. And this is a very important backbone to everything that we do. This next slide sort of summarizes our field of sexual medicine. People say, I don't know what sexual medicine is. geez, I've heard of emergency medicine and family medicine and so forth. So sexual medicine is basically whatever those are, but it's a medical discipline like everything else, but it embraces the study, the diagnosis, and the treatment of men and women with sexual health concerns. I wish there were many more sexual medicine doctors. There are many people, men and women with sexual health concerns. So our object is to provide scientific, evidence-based, psychologic and biologic strategies with the person and the partner to help them with their despair, distress, humiliation, frustration with their sexual health problem. On the other side of that slide, if I can go back, you can see we have journals of sexual medicine. We have 3 of them: the Journal of Sexual Medicine Reviews, and the Journal of Sexual Medicine. And this is, I'm the editor of the Yellow Journal, actually. So now we're going to get into some data. This is an epidemiologic study that shows the conditions that people who have sexual problems with they complain of. So we have people who complain of pain during sex. And you'll see we divide them by gender. The orange group are the women, and the sort of yellow group are the men. And you can see far more women have pain during sexual activity than men. And other issues like not pleasurable sex and difficulty achieving orgasm and lack of interest. And I made a sort of a red rectangle to show that these issues can be many underlying reasons for having them, but at least neurologic sexual dysfunction, which is what we're going to spend some time on, will be engaging in. If you have a neurologic sexual dysfunction, you could experience pain, you can experience a sexual event that's not pleasurable, difficult to achieve orgasm, lack of interest, anxiety about your performance, etc. So these are not specific to, but consistent with a neurologic sexual dysfunction. I have to call out my very favorite sexual medicine society, the International Society for Study of Women's Sexual Health. Both Eveline and Linda have been recognized for their contributions to women's sexual health through this society. It's a multidisciplinary academic and scientific organization whose purposes are really to supply scientific activity and understanding and teaching to women with sexual health problems. For women, I know this is a conversation about men and women, but we'll focus here on the women. One of the problems when you address women with sexual health problems is you cannot see, or the patients cannot see, their pathology. They have great difficulty time seeing their genitals. So we have a device called a vulvoscope. We strongly promote the use of vulvoscopy. It allows us to see basically genital tissues. These 3 boxes are genital tissues in a disordered state, and these would be after a treatment state. This picture here is showing a clitoris that's smaller than the Q-tip, and now a clitoris after treatment, which is the same size as the Q-tip. This is showing redness at the opening to the vagina called the vestibule, and this is where the redness has gone away. And this is showing an actual G-spot or prostate in the vagina, anterior wall of the vagina, one which is not robust and one which is robust. And the only treatment done here is the hormone testosterone. So one of the reasons for having a sexual problem could be you have a lack of hormones. And one of the things that sexual medicine doctors do is record hormone blood tests. So this is a woman as they enter menopause. This would be the perimenopausal state. This behind the red dots would show you the estrogen level, and they're robust. And then around age 51, they fall, and they go on to the values that are consistent with children prior to puberty. They have essentially no estrogen, and the menopausal women have no estrogen. This is 1 year, the look of the opening to the vagina compared to the control prior to menopause. And the next sort of vision is 6 years into menopause, again showing the association of hormones to genital tissue health. So this would be a person who would have pain during intercourse, difficulty with lubrication, not pleasurable, difficulty with orgasm, where hormones would be a benefit. We have a picture here which shows these 4 pictures are those who didn't get treatment, and those, it's the same person now on treatment. You can see their improvement. We have for women in menopause treatment with a hormone called testosterone, And yes, testosterone is important in women, not exclusively for men. Estradiol, progesterone are the systemic ones for which we measure hormone values. And these are local treatments which allow us to show the tissue health as we see it on vulvoscopy. These are the befores and afters, and these are the befores and afters. You can see a lack of a robust G-spot prostate area, and you can see it growing with the treatment. So we're going to switch sort of topics now. We've gone from women's sexual health to a genitopelvic dysesthesia. A dysesthesia, as Sue said, is an unusual feeling or a weird or abnormal or tingling or buzzing or humming or vibration or even lack of feeling is an unusual feeling. And these are women who have a condition called persistent genital arousal disorder. This is a study published several years ago in the year 2016 showing that women who have PGAD have high association with despair, emotional lability, catastrophization, and suicidality. It's really one of the most horrible of the sexual problems. They have unwanted shame, continuous symptoms, unhappiness, etc. Here's another study which continues to show the suicidality, ideation, severe depression, suicide attempts. It's really important for us to manage these women carefully to help them in their process. So the International Society for the Study of Women's Sexual Health put together a consensus meeting to define the condition of PGAD. It's a disorder characterized by persistent or recurrent, unwanted or intrusive, distressing, so those are three key categories, feelings of genital arousal or being on the verge of orgasm, that's called a genital dysesthesia, not associated with concomitant interests, thoughts, or fantasies for greater than 6 months. And it could be associated with despair, emotional lability, catastrophization, and suicide. This is sort of a formal but now generally accepted definition. Now, how often do people have PGAD? Some people say, well, why do we talk about this? It's so rare. Well, we talk about it because it's important, but it actually isn't so rare. In 2 independently done epidemiologic studies, roughly 1% of the male and 1% of the female population has PGAD. So if you translate, we have 165 million women in the US and 165 million men in the US. Roughly 1% would be greater than 1 million each of men and women have PGAD. That is no small prevalence number. I want to point out that this is an fMRI, an MRI that shows anatomy, but this functional part shows blood flow. And I want to spend a few seconds on this slide. These slides are from Dr. Barry Komisarek. He's our favorite neurophysiologist who directs us to understand the basis for many of these problems. Dr. Komisarek showed intense, I will use that word again, intense sensory activation in the region of the brain where the genitals are represented. So if this is called the homunculus, where all the representations are of various body parts in the sensory aspect, the paracentral lobule right here is where the genital is represented. The genital is represented here. This is where the hands are represented. So this woman in the fMRI unit was asked to basically touch her clitoris. So these hands are moving, and she's feeling with her hands, and the clitoris is represented in the paracentral lobule, the genital sensory location in the brain. Now, this is a PGAD person. This person has intense sensory activation in the paracentral lobule. Look at the difference between that size and that size. And the person is not stimulating her clitoris. She is just standing there in PGAD. To get any sensation, you have to touch it in a normal situation. In PGAD, you have grapefruit-sized intense activation without doing anything. So it's unwanted, unremitting, it's distressing, and it's involving the genital area where you get these feelings of arousal or other dysesthesia feelings. Now you'll see other representations of the brain here, and these are projections to other regions of the brain involved in your suicidality, catastrophization. So project that Dr. Kamazarek did has been extremely helpful for us to better understand these issues. Now, what is triggering this intense activation is our job to be the detective. What is it that's triggering? We need to find it. So we look in different regions. So we have different regions. We have the region of the end organ. In men, that would be the penis. In the woman, it would be the clitoris, the labia, the vagina, the perineum, the rectum, the uterus area, all of those regions that are at the end of or the beginning, if you like, of the journey. And then there's a pathway to the pelvis and perineum that takes us to the spine area. Then there is in the lower part of the spine, the upper part of the spine, and the brain. So we have 5 regions, region 1, 2, 3, 4, and 5. In region 1, it could be that the clitoris is sore. We call that clitoridyny. It could be the vestibule is sore. We call that vestibulodyny. It could be that the urethral is sore. We call it urethral pain, and on and on. In the pelvis and perineum, it could be the pelvic floor. It could be a pudendal nerve problem, pelvic congestion syndrome, a condition of arterial venous malformations. In the cauda equina, Dr. Kim is going to talk to you all about the cauda equina. That's the lower part of the spine. You could have a situation called a Tarlov cyst. You could have a situation where there's an annular tear, or various reasons. Dr. Kim will explain that further. Further up the spinal cord could be other issues, and then, of course, the brain. So our job as detective to try and help understand where the trigger is to do diagnostic studies for all of that. So I'm going to end my talk saying thank you for this opportunity. Thank you for listening. It's an honor to be here. You have the right to sexual health, whether it's PGD or something else. You have sexual medicine facilities to take care of you. You have societies to take care of you. And we're now going to listen to Dr. Kim's talk. Thank you very, very much.
Okay, thank you so much. Bear with me while I change the slide deck. This may be kind of fun. Please stand by. Almost there. Sorry, guys. Oh, thank goodness it's working. Okay, I think this is going to be a good day. So, I don't know if you could appreciate how complicated this whole field is. And let's face it, sexual function has to be complicated because it's not like walking. It involves a lot of different things. And so I'm kind of lucky. There's a multitude of things that can be happening, but I just have to worry about the parts that occur in the spine. So I just have to thank Irwin and Sue and Barry, because one of the things about today's talk is that very few spine surgeons know about this problem. And I've known Dr. Goldstein for 11 years now. It took him 6 years to convince me to start looking at some MRIs. That was 5 years ago. And since then, I've been stupefied about how distressed patients are in this category of disorders. And finally, we have, at least for a small group of people, some treatments. So if you look at just the overview of the causes and the evaluation and treatment, this is kind of the way my brain works. I know this slide's hard to see, but sexual dysfunction's up here. It's caused by a variety of different things, and it's very complex, one of which could be neurologic. And of course, that makes sense. If you have a neurologic disorder, you're going to have problems with sensation and function. Now, within that category of neurologic problems are a bunch of other categories, and I want to focus down even tighter than that, all the way down to a very specific area of the spine, and that's basically the low back, the lumbosacral spine, where, if you think about it, a lot of the nerves that go to the pelvis originate from that location. So that just makes perfect sense to start with that location. And also, that area is a lot easier to treat surgically than the other areas, because the other areas are the brain and the spinal cord. And when it comes to surgical difficulty, the lumbar spine is the easiest in terms of complications. The brain is the most difficult. That's a gross oversimplification, but I think you understand what I mean. And we're focusing on the lumbosacral spine. So I hope you're following that, because this is a lot of information all at once. So, and I want to show this slide. This is one from Barry Komisarek. Look at all these nerves that go into the pelvis. You can just imagine how complex that is. And The key thing is that in my leg, the main nerve system is called the somatosensory nerves. It's the dumb nerves that let me fire my muscles and feel pain and irritating kind of sensations. But think about your guts and your sexual function. You don't have like voluntary control over those things. So those organs are controlled by the sympathetic and the parasympathetic systems. For example, the parasympathetic system may be responsible for erections and the sympathetic system for orgasm. That's a gross oversimplification, but you can just see the one order of magnitude level of complexity when it comes to sexual function compared to the functioning of my foot, which is kind of dumb when I think about it. Okay, so let's now kind of get to the point where we have decided there are a group of patients who have a sexual dysfunction, and we've whittled down the potential causes to this small group of people that have problems in their lumbosacral spine. Now what? Now, I'm a surgeon, so of course, I'm always thinking about problems as follows. Can I fix that problem with surgery? Because when you're a hammer, you're kind of looking for nails. And just as importantly, can you do a surgery that's reasonable? Because let's face it, some surgeries are just so big and dangerous, they may not be worthwhile pursuing, especially at this early point in time when we're just learning about these associations. So, what is something that we can reasonably treat in the lumbosacral spine when a patient has pelvic dysesthesias? Well, one simple thing is a herniated disc. So I don't know if you can see that, but see this thing just poking out like a little rock versus these other levels where it's nice and smooth? Well, when that pokes out, it could pinch a nerve. But more importantly, whenever the body has an injury, it says, I have an injury and I must try to fix it. And it mounts a repair response. That repair response is almost always involves inflammation. So if you don't have inflammation, you will die of an overwhelming infection. You know that, what's that movie about the outer space aliens? And as soon as they open their door, they all like wither away and die and shrivel up because they get inundated with bacteria. That's what would happen to us. We'd be like an alien coming to this planet. We just turn gray and just become dust. But sometimes that inflammatory system goes haywire and it can actually cause problems instead of help them. And when you have a herniated disc, this could cause pain shooting down your leg, or it can irritate the nerves that go to your pelvis. They all go by that area. And if you just have the perfect storm of abnormalities, that nerve will go haywire, and all of a sudden, something that is pleasurable kind of sucks. What's another treatable problem? Tarlov cysts. These are things that for the longest time in my career, and I've been around for not as long as Dr. Goldstein, but I've been around for a little while. If you get a close-up, you'll see like, wow, he's a lot older than I thought. We used to think Tarlov cysts were incidental findings, and that's where Barry Commiserat comes in. I wish he could be here, but he's the one that made this association, told Irwin. Irwin then hounded me in a polite kind of mentorship kind of way, like, I'm coming over to your office with a stack of MRIs and you're gonna look at them with me tomorrow, kind of way. And when I looked at it, I said, well, those are incidental findings. I highly doubt that's gonna cause symptoms. But turns out in some patients, not all, but in some patients, that Tarlov cyst can cause terribly distressing sexual dysfunction. And then finally, these little things called annular tears. So I think you can see this little white spot right there. That should not be there. That is a tear in the outer part of the disc that holds everything in. So the disc has two parts. The center part, you can see this little bright area, is the gel. It's called the nucleus. It's the shock absorbing feature of the disc. So imagine Coke cans stacked on top of each other with shock absorbing disc in between. The way that works is that you have a gelatinous core, and to prevent that core from squirting out, it has a rind of very dense collagen fibers that holds everything in. That's called the annulus. Now, over time, you get fissures, and if you get a tear, that goo will start making its way out that tear, and if you're unlucky, that goo will come squirting completely out of the canal. If it's a massive disc herniation, there is an entity that all spine surgeons know about. It's considered a medical emergency, cauda equina syndrome. You have a massive disc herniation. It compresses all the nerves in your back, going down your legs to your pelvis, and guess what happens? You get urinary incontinence, saddle anesthesia, severe pain and burning down your legs, and most likely sexual dysfunction. But my guess is that when somebody's in the middle of a Cauda-Equina syndrome, they're not really caring about their sexual function at that moment since they can't even hold their urine. But it just makes sense that if you just ask, well, what if the discriminations are smaller? Could you still get a kind of Cauda-Equina-like syndrome? Of course you can. You just never thought about it like that. So even an annular tear like that, if it mounts a crazy inflammatory response and irritates all the nerves that go by there, it will also irritate the nerves that go to your pelvis and can cause you sexual dysfunction. So these are the types of things that we can do a little tiny surgery on, and in some patients, they get dramatically better. All right, so what has that experience been like? Like, you're probably like, get to the point, what did you find, Dr. Kim? So in 2015, I believe Dr. Goldstein had a patient who committed suicide, and he just said, that's it, I'm gonna go see Choll, I'm gonna force myself on him. And he really opened my eyes to our experience. So this is what it's been like. All right, so every week or two, we get together and we just go over a pile of MRIs. These are all patients that Dr. Goldstein takes care of. And he's evaluated them for all those things that we talked about: hormonal, local, traumatic, etc. And when he gets down to the point where he says, okay, Choll, I think this patient is probably a spine patient. We get the MRI and we look at it in conference. Dr. Komisarek is right there. He's joining us by Zoom, and we go over MRIs and we make treatment plans. And since then, we've looked at a lot of patients. So it's probably more than that now, but we've looked at over 600 patients. And by the time they funnel down to the treatment pathway that seems reasonable, we've done 57 surgeries. And this is a big group of patients with a variety of sexual dysfunctions. So what I want to do, just for the sake of clarity, is to just focus on 3 subgroups of patients. Patients that have what we call PGAD, a painful genital pelvic dysesthesia, that we treat by laser endoscopic surgery, a very minimally invasive Band-Aid surgery designed to not create a whole new set of problems just in the process of doing surgery. Also, we have a few patients that have been treated with a Tarloff cyst. For some reason, in our practice, the majority of the patients that have hypersensitivity disorders like PGAD tend to have annular tears, but a bunch have Tarloff cysts. And then I want to talk about this group that I call PDOD. That's a group that instead of having like a hypersensitivity problem, like hyperarousal, pain, dysesthesias, they have hyposensitivity. They have trouble sensing pleasure, have trouble achieving an orgasm. So that is a much more difficult group of patients, but there's a subgroup that we treated also through the LES procedure. The reason why I like the LES procedure is that it takes small problems to cause big sexual problems. So if you do a big surgery, I'm fearful that the surgery itself can be a problem, but we haven't gotten there yet. So we're just starting with the most safest, most state-of-the-art minimally invasive surgery to try to minimize surgical comorbidity. All right, so let me talk about group 1. PGAD patients treated by the LES procedure. We've operated on 21 patients, and here's how we figure out how patients are doing, among other things. I mean, we have a bunch of tests, but in the end, here's the way I think. The patient has to experience an improvement. So one of the things that we do is we ask the patient to tell us what the results of their surgery was from their perspective, and the answer is simple 7-point scale, a Likert scale that we call PGII. This is a peer-reviewed
Patient Global Impression of Improvement.
No, this is a peer-reviewed, validated study, which stands for Patient's Global Impression of Improvement. I know it's fancy, but it's published by peer review, so this is what and you just answer the question: am I very much better, a little better, no better, a little worse, much worse, very much worse? A 7-point Likert scale. Okay, I just got a question that says, explain what LES is. So imagine you see that annular tear. You go in there with a tiny little poke hole using an endoscope that looks like a knee scope, and you go right to that annular tear and you basically treat it by 1, removing any trapped fragments, and then 2, using a combination of the radio frequency probe and the laser to treat all this abnormal inflammatory tissue that's been perpetuating this abnormal inflammation. So it's a surgery that takes like less than an hour. Through a little poke hole, we put a Band-Aid on there and patients go home the same day. And you'll see the results in a second about how that works. But the main thing is that it's not a big spine operation. So these are the numbers that people answer to each of these questions. So what does that basically say? Overall, there's a 76% improvement. If you say success is very much better, or a little better. Now, if you want to get really kind of like strict and just say, I don't like the little better, I just want to know how many are very much better or much better, that'd be 67%. We had 4 that didn't get better, unfortunately, but they didn't get worse. And then we have 1 patient get very much worse, but I don't think that was related to the surgery, but that is right now our kind of very much worse complication rate for this procedure. Okay, the second group of patients are the ones that had a Tarloff cyst, and we only have 4 of those patients. So same thing, we do the surgery, Dr. Goldstein and his team does a bunch of objective evaluations, and then I do the see, I'm a spine surgeon, so I just want to keep things simple. I just want to know if they're better, same, or worse, and they answer the same set of questions, and these are the answers, and that basically boils down to a 75% improved, 50% much improved if you want to be really strict, and 1 patient did not get any better. Now, this is only an N of 4, so we still have to get larger numbers to get an idea of what the performance characteristics of the surgery is. But I can just tell you, this surgery has been done by other people, and the results are dramatic. So my guess is that as we find more patients that have Tarloff cyst and PGAD, we're going to have a much higher success rate on par with the less procedure. But that remains to be seen. And then the third group of patients is the hyposensitivity patient. They're the patients that try as they might, they cannot get enjoyment from sexual relations for a variety of reasons. And essentially, they're in this category of patients where their symptoms are marked by a decrease in sensitivity or hyposensitivity. Much more difficult to work these patients up, but that's a topic of another story. But here are the results of 19 patients. We lost 2 to follow-up, so I only have numbers on 17 patients. You statisticians out there will probably go, Choll, you should add in the 2 losses of failure. That's the only fair thing to do. And you're probably right, but let me just show you what we have, and we can talk about the statistics later. The improvement in the hyposensitivity patients aren't nearly as great as the hypersensitivity patients. But these are still patients that have undergone probably 10 treatments already, and they've practically given up. And this has been like their last kind of treatment. 8 patients did not get any better, and we had 2 patients that got slightly worse. And 10% was lost to follow. So I have no idea how long I was talking, but I told everybody we should only talk for 10 minutes. It was probably 30. But here's the summary as I see it. The spine can cause sexual dysfunction. Does it cause sexual dysfunction in everybody? No, of course not. That'd be silly. But there are a group of patients. We just have to find them. And that group of patients are so distressed compared to my normal spine patients that have back pain and sciatica or low back pain, which is a very distressed group to begin with. They're nothing compared to our sexual medicine patients. So it's so gratifying when we can find a patient that we can help. And then I also just want to say and remind everybody, I don't want people to take home the message that the spine causes all sexual dysfunction. It's a minor proportion. And what I've noticed is that most patients have multiple causes. And when we treat the spine, one of the things that it probably does is that it allows the other supplements, other treatments to work a lot better. It's almost like a bottleneck. But keep in mind, sexual dysfunction is complicated, and of course, there's a multifactorial cause. And here's the other thing that we noticed that's new. Small, minor abnormalities that a lot of spine surgeons will just say, that's nothing. Those are the patients that have just as bad distress in terms of sexual function, and those patients actually do a lot better, probably because we've intervened earlier in their disease pathway. You stand on my toe for too long, and if you step off, it's going to keep hurting for a lot longer than if you just stepped on it for a short time. Same idea in the spine. And for right now, we're really trying to use minimally invasive, state-of-the-art strategies to minimize all the what we call collateral damage of surgery, because typically we just go barreling in there, blood everywhere, and we fix a big, really bad problem. Right now, we're trying to fix these little minor problems that cause big symptoms. So you can't take care of these minor problems with a big surgery. You got to really focus on minimizing the surgical comorbidity That's my hypothesis. I don't know that for a fact. Could very well be that you can do a big surgery on these patients, they also get better, although I highly doubt it. And of course, we just have so much more work to do. And I have a lot more to learn about sexual medicine, but this is a big deal. And it's a new field. And I think this is a group of patients that basically we just abandoned because we didn't know that they were there. And this is an opportunity for us to take care of some patients that we didn't know needed taken care of. So thank you so much for joining us. Sue's going to come back up and help coordinate questions and make sure we get done on time.
Thank you to both our presenters. I'm going to let you see this slide up here. This is the homepage for the Center of Excellence for Genitopelvic Dysesthesia. You can find it at spine-sexmed.org. And that is where we'll be posting PDFs of the slides today, so you'll be able to see them better. Just to let you know, the Center of Excellence for Genitopelvic Dysesthesia is actually a virtual facility because Dr. Kim's office at the Spine Institute of San Diego and Dr. Goldstein's office at San Diego Sexual Medicine are in adjacent buildings. So our patients are able to easily coordinate going back and forth, but the Center of Excellence is not actually a physical being, so they just wanted you to know. Also, for many of you who are going to take this back to your doctors in your local community, this is state-of-the-art medicine. This is not readily available as far as we know. Most clinicians are not familiar with this content unless they've been to ISWISH or SMSNA, two sexual medicine societies, and have learned about it. So I don't want you to go home to your local clinician asking them to do the tests we do, find a local surgeon to do the surgery, because they will not be familiar with this most likely. We don't want you to be concerned. I'm not trying to say you have to come here, but I'm saying is don't get frustrated if your local clinician doesn't know what you're talking about, because you probably know more about this after this brief lecture than before. But we will get those slides posted, and at this point, we're going to bring Dr. Karmasarik in on phone in addition, and we're going to start questions. So I'm going to bring our specialists up. And our first question is there an age limit, an upper age limit to be a candidate for less surgery?
No, there is not actually. For the surgery itself, but there's probably age limits to why we do the surgery, but there's really not an age limit. It depends on what your symptoms are and what we think might be causing the problem, and if that problem can easily be treated with the less procedure, because again, the less procedure can't treat everything. Basically, herniated disc and annular tears.
So how young could a patient be? Because I think we have an 11-year-old, we have 15-year-olds and 16-year-olds. When would you feel comfortable operating?
I can't believe you just asked me that live and pressured me.
I'm pressuring you.
Well, until we have more numbers and we know better all the things that's going on, I'm so nervous to operate on a minor. But at some point, we have to identify patients. Thank you. That need the surgery, and if they're 11, I guess we have to work it up. But
Okay.
I don't think we know enough about the disorder yet to.
You would contemplate it in a minor?
Of course, yes.
Okay, thank you.
But it would be nerve-wracking to kind of operate on an 11-year-old.
So we have women whose PGAD isn't from the spine. It's from a condition in their vestibule, the opening to the vagina. That's called congenital neuroproliferative. And it's very complicated for us when we operate on that patient population because they have to stop growing. But so I brought it up for you with the spine. Okay.
As usual, Dr. Goldstein is a light year ahead of me, already thinking about what we're going to do, 10 years from now, but he wants to do it tomorrow. And that's great. That's how I got here to begin with. So thank you. But there's so many things we need to address. And apparently there's a large group of children that have this disorder too. So
lifelong.
Lifelong. So we have to figure out
horrible
etiologies and carefully, systematically, and cautiously work those patients up to see what we can do. That's the way I look at things.
Thank you.
So somebody said they have 2 Vertiflex devices planted in the spine, treating bulging discs. This seems to make the PGAD worse. Can either of you address that?
Okay, so let me address it from a spine standpoint. So the intraspinous process device is designed to go in between the bones in the back to splay everything open. That is a very good device to treat a problem called stenosis, but it doesn't necessarily treat herniated discs or annular tears. So it's very possible that that procedure irritated something and elevated the inflammatory cascade, because it's not directly treating what may be the inflammatory pain generator, which would be in the disc. So that's probably what is going on. But again, we'd have to look at all your imaging to sort that out.
So let me bring up a point, if I'm allowed. So we have this device called low intensity shockwave device, and it's widely used for back problems. It's widely used for tendonitis, arthritis, bursitis, inflammatory conditions. And we have had some positive experiences in people after surgical interventions, annular tear repairs, Tarlov cysts, and I don't know what this spacer thing is, but let's call it a spine surgery. That if there is an underlying inflammatory condition, radiculopathy, still present, this non-invasive device can knock down that inflammation. So that's another thing. If in fact the shock wave made the PGA symptoms less, not less surgery, reduced, perhaps we could then do more studies and see if there's an annular tear that could be addressed through the minimally invasive surgery that you do.
Yep.
Yeah.
There's a lot of avenues of potential treatment. We're really focusing down on a narrow group of patients, but little by little, we're going to just naturally expand the patients that we take care of and the treatments that we start instituting. So I think that speaks to the multifactorial component of the disorder. I may be treating the spine on that annular tear, but I notice people still need to be on hormonal therapies, need pelvic floor physical therapy, and then the shock wave is pretty amazing. I don't understand how it works, but people have been using it to decrease inflammation through this mechanism. So we've had several patients that after surgery, they have a little bit of residual symptoms, they get the shock wave and they get better. So my thinking on this is that it's a multifactorial, multidisciplinary treatment, and shockwave would be just one of those spokes in that wheel.
Well, almost like a TENS unit or something.
Yes.
Like that.
We have a question. We have 5 minutes.
Okay, we have a question. How common is foot arousal, and does the presence of that symptom aid in the diagnosis of PGAD? And I'm wondering if Dr. Karmasarik could address that, because I believe it may have something to do with the brain. Dr. Karmasarik?
What was the question? Was how common is what?
Is foot arousal, and is it related to PGAD?
Foot arousal. Well, the representation of the feet is right next to the representation of the genitals. So it's very possible that with an irritation of the genital sensory nerves, there would be a feeling of arousal in the feet. As a matter of fact, there's a book by Ramachandran in which he says that he talks about people who have amputated feet, and what happens is that the people describe, men and women describe, that they have orgasms in their phantom foot because, and the idea is that the nerves from the feet and from the genitals go to basically the same place, almost the same place in the brain, so it can spill over from one region to the other. So there's it's very likely that problem if you have, well, I'd like to know exactly what you mean by foot arousal. Is it a sensation? Is it a pleasurable sensation?
Well,
is it uncomfortable? Is it pain or what?
We don't have the patient on. He's just sending a note, so I think we're going to end the conversation here and move on.
Wait, no.
Okay, Dr. Goldstein,
could
please
you bring him
address that.
back? Is Barry still on?
He's still on, yes.
Barry, thank you. You're amazing.
Yeah.
We talked about this the weekend, and then on Monday, I had a patient who, in addition to clitoral arousal, had nipple arousal associated with the PGAD. And do you want to explain that as well?
That's the same idea. We found that the nipple actually projects to two places in the nipple. The nipple actually projects to two places in the body map. One place is, of course, the chest area, and the other is directly to the genital region. So the same neurons that respond to genitals respond to nipple stimulation, and that's probably why nipple stimulation feels erotic.
Thank
Many
you,
people
Barry.
have said that
You're
nipple
like
stimulation
amazing.
feels erotic.
Only you know all this stuff. It's awesome. Thank you.
This field is so complex. I mean, it's just, there's so many brain issues too. And that's an example when the same area of the brain has to monitor your feet and your genitals.
And your nipples.
And your nipples, there will be cross reactions. So it kind of makes sense.
That's right.
I thought I was just kind of like had a foot fetish, but now it makes sense.
So we have a really good question, which I think was basically with everybody. If you're ground zero and don't know what the source of the PGAD is from yet, what are the steps taken at the beginning of the investigative space? How do we start this trip of trying to find out what's wrong?
I mean, I'd be very happy to answer that.
That's a Dr. Goldstein question.
Can't you answer this in under 3 minutes?
Yes, I think there are different levels of expertise required. So at the basics, you need a history and a physical examination. Physical examination needs to include the genitals, so it depends which gender. Basically, if an area of tenderness is identified in the exam, let's make this a woman, and let's make that we have a Q-tip and we touch different regions of the genital and they're exquisitely tender, then what we will do, and anyone can do this in ground zero location, not have to shuttle their way to San Diego, you can numb the area with lidocaine, make that region less tender. If the persistent genital arousal goes away, then we can safely agree that the PGAD is triggered by that abnormality. But it's extremely common to find something that is inflamed and irritated, and when we numb it, it bears no relation to the reduction of symptoms of PGAD, meaning that where we numbed it is not the reason for the PGAD, and we have to look elsewhere. Typically, we move upstream. So if it isn't the clitoris or the labia or the vestibule or the rectum or the perineum, we'll go to the pudendal nerve or pelvic floor, where we can do pudendal nerve blocks or we can do trigger point injections for the pelvic area. And if that doesn't work, we then get an MRI. You can do that at ground zero. Everybody has MRI facilities. We accept your MRIs. We'll read them and get back to you as to what we think is treatable. Dr. Kim, maybe you want to comment on it, can identify what he believes to be treatable spinal abnormalities. We call those TSAs. And then at that point, maybe it's time to move from ground zero to more specialized location. But it's an organized detective strategy. That's to find the cure. Let me just spend 1 second. There are a number of medications, probably 15 different medications, that based on their mechanism of action and site of action can be used to reduce the symptoms while the doctor is playing detective trying to find out where the cure is. Do you want to comment on anything else?
The only comment that I have is that you need to find somebody like Dr. Goldstein that can step way back and has the foundational knowledge to kind of look at all the different potential causes of sexual medicine. And I'm really like the mercenary that's waiting for him to filter down the ones that have a spine problem, and then we work those up. But you don't want to start with that. You want to start with the top and go through all the different things and treat the easiest things first, and only get down to surgery when it's necessary or worthwhile. But you need to find a really good...
Can I add something?
Please.
Barry, thank you.
To extend what Irwin was saying about the injection of the lidocaine, Choll, I think could you say something about the diagnostic procedure that you use in the spine before you do the LES procedure? Because you didn't mention that you do something comparable to see if you eliminate the symptoms with a local injection in the spine.
Thank you, Barry.
Okay, so that what Dr. Komisarak is talking about is the diagnostic testing that I employ when we get all the way down to the spine. But doing diagnostic blocks with an anesthetic in general, in all areas of the body, is a good way to confirm that that area is causing that pain. So if site A may be causing pain 1, and you numb up site A and no longer have pain 1, then you can reasonably infer that site A is causing pain 1. Did I get that right?
You did.
And turns out the injections that we do in the spine, where we numb up the disc, the Tarlov cyst, etc., we also put in steroid to decrease inflammation. Dr. Goldstein will do pudendal nerve blocks. We'll do VATS, which is a
Vestibular anesthesia test.
Yes, what he said. and a variety of different blocks to identify pain signals. So we use diagnostic injections for a lot of patients to fine tune and confirm our anatomic diagnosis. It's a way to like point to a region in the body and ask, is that region contributing significantly to the spine? So specific targeted epidural steroid injections as an example, Tarloff cyst perineural blocks, et cetera. So we rely on a lot of diagnostic testing before we employ surgery. So that's why we started with like 600 and something and get down to only 50.
So if somebody has had surgery for an annular tear, is it possible a couple of years later to have a new annular tear causing the same symptoms, and would they be a candidate for surgery? Or are there medical ways of treating somebody whose PJD has gotten significantly better after surgery but not 100% treated? So that's each of you.
You want to answer part two? Because that's the
I
important
mean, each new PGAD presentation needs an evaluation. We would do appropriate history and physical assessments and diagnostic tests. We do tests called neurogenital tests. We measure the integrity of these nerves to see if they're working or not. So a second PGAD experience would need to go through similar evaluation. And then, of course, the MRI could show a brand new annular tear at a different level. I mean, maybe you can talk about that.
Well, the first thing is the second half of the question. A lot of our patients get a lot better, but still need continuing treatments in other respects. The one that I see the most commonly is they really benefit from postoperative pelvic floor therapy,
Yes.
both pre-op and post-op. Should try that pre-op first before having surgery, but post-op helps a lot. Shockwave helps a lot. And then the rest of the patients they're so different. They are on different combinations of medicines and treatments. That's the part I noticed. And then the part where a patient will have an annular tear, have PGD, have surgery, get a lot better. We have had one or two patients like that. It's not common, but of course you can get another annular tear because when you treat the first annular tear, the disc is still acting like a shock absorber, and you can get a second injury, just sort of like you can have a re-injury of your knee after surgery. So
Dr. Kim and I both want to emphasize we're both surgeons, and we sometimes forget the role of sex therapy in all of this. And we describe this as a multimodal event. We have a sex therapist as part of our strategy, and sex therapy is very critical. There are many avenues and strategies for reducing catastrophization. To focus on and distract yourself is another great thing, reducing anxiety, dealing with traumas in your life. We have many patients who, concomitant to surgery, get sex therapy approaches. We don't want to forget this contribution.
So while you're talking about that, we have a question about flares. Why is it that someday you have a low level and you can distract yourself throughout the day, and other times you have a flare that's so intense you can't do anything but think about that? Do we know what causes flares?
So that's the definition is persistent or recurring. So the word flare is concomitant to the concept of flaring. So it would depend on the basis of the trigger as to what the flare is related to. You could have something wrong in the clitoris, like closing of the hood and an infection, and now instead of you're lying in bed, you're wearing tight jeans with a seam, and that's rubbing against the clitoris. That could cause a flare. You could be lifting something heavy, you have an annular tear, and maybe that changes the dimensions of the ooey gooey material, irritating the dura, irritating the sacrospinal nerve root. I mean, there's many differences, explanations for PGD and different reasons and explanations for flares, but it's a common characteristic of PGAD to have flares, I must say. What's other interesting, and Barry, maybe you want to comment on this, is the natural history of PGAD. In many cases, it sort of starts, it gets worse, and you could argue in some cases, as the nerve sort of stops being irritated, it gets to a situation where, in fact, hyposensation turns up, where people cannot even feel their genitals anymore. So it's a change from PGAD to the other aspect. Barry, you talk about this. You want to talk about this now?
I could say something about it, but I also have a question for you. What you're saying is it's an interesting possibility that it starts out as a low-level intensity, and then because of some change in mechanical stress, it can get more severe, and then with continued long-term irritation, it could become insensitive. But a flare, it seems like one question I have for you is whether there's any correlation with the menstrual cycle. Do you have any of the women described changes in susceptibility to the PGAD symptoms changing over the menstrual cycle? Like, does it get worse in the premenstrual period, for example?
Sure, because in the premenstrual period, there's essentially no estrogen, no progesterone, and tissues that are responsive to that can get more and more irritated, at least tissues that are really dependent on hormones for their support. So someone whose PGAD flared during the menstrual cycle, one would consider that region 1, the location of the vagina, the clitoris, the vestibule, would be a suspect area as contributing to this intense sensory activation that we talk about in the paracentral lobule, because it doesn't make sense that an annular tear is related to, for example, a menstrual cycle. But it does make sense that an external genital and maybe even an endometriosis lesion, an implant somewhere that's irritating maybe the pelvic nerve, could be implicated. I mean, yeah, these are all reasons why we take good and comprehensive histories for these patients.
Another possibility is that there are changes in mood that can influence sensitivity to pain. Changes in medication can change the sensitivity to sensory stimulation. If there's chronic irritation, the perceptual sensitivity to pain or itch or any kind of sensory stimulation, these change with mood and with pharmacology, with pharmaceuticals. So there could be many different factors that could account for flare, seems to me.
Yes, and I would say on top of all that, there's your body's state of inflammation as it relates to what we call homeostasis. Our body's this complex mixture of, machines and chemicals, and it's trying to kind of keep it kind of stable, but let's face it, it's complicated, and our body's inflammatory system goes up and down. And by the way, most Americans are in a heightened state of inflammation, but that's a subject of a different topic. But I've noticed, at least in spine patients, when one thing hurts, a bunch of other things becomes a problem, and it kind of reflects our body's heightened state of inflammation when it's struggling with something. So staying really healthy and fit on top of all this is a really important step in maintaining the symptoms in a kind of a neutral, quiescent state from an inflammatory standpoint. Okay, it is almost 5 o'clock, so we have to wrap up.
But we will look at the website for the next 10 minutes and try to answer your questions online for the next few minutes so that you can all see that. We're going to shut down the video portion. The posting of the PDFs will be on the website for the Center of Excellence for Genitopelvic Dysesthesia, which is written incorrectly on Dr. Kim's slide. He will get that corrected.
My fault.
But it is spine-sexmed.org. We probably will not get it up until tomorrow, the day after, so please be patient. But we look forward to seeing future presentations such as this, and feel free at any time to call to become a patient if that's of interest. I've just addressed that to somebody's question on Facebook. You can see how to do that. But pretty simply, we offer a free 10-minute courtesy call to learn about this through San Diego Sexual Medicine, and that's actually how we start the whole process. We work in cooperation with the Spine Institute. We will do all this cooperation, and that's what the Center of Excellence is. It's a cooperative group. So feel free if you'd like to explore it. And that 10-minute courtesy call does not require you to become a patient. It is simply an exploration of all of this on how to work with Dr. Kim and Dr. Goldstein. So thank you very much. We appreciate your being here. We'll see you next time.
All right, thanks, Choll. I think the next time we'll do a formal webinar instead of a Facebook Live thing. You can't see the slides, and we're walking back and forth. I think next time we can get Dr. Kumizrak on board. So keep an eye on my Facebook page or Instagram or however you heard about it for another event, and we'll do it with a webinar setting since it's gotten so good. And again, thank you. And I look forward to seeing you all next time and reading all your comments because there seems to be a lot of them. So thank you.